I just wanted to thank Greg for inviting me, and I want to just thank Richard Harvey, who's my co-researcher and has contributed significantly to the slides and to the research that goes behind this talk. There's my disclosures, none of which have any bearing on this. So when we talk about chronic rhinosinusitis and polyposis, there's a whole lot of factors that have been typically published in the literature over years. They're patient factors, disease factors, institutional factors, surgical factors, a whole lot of things. And what are these that have been published? Well, the patient factors, people always talk about whether there's prior surgery is going to impact, whether the number of surgeries, whether there's systemic disease. There's a whole host of things that come into play when you assess your chronic rhinosinusitis patient, as well as the disease itself. There's a whole lot of things that are negative and positive prognostic factors. That's not what I'm going to talk about today. What I want to talk about today, I want you to think about the sinuses as being part of this unified airway. The sinuses being part and parcel of a single functional unit. The sinuses are really, really complex. And I think it's inappropriate, and I think Brent really ran that hammer home in the last panel, that it's inappropriate to apply simple concepts. Is this just a blocked problem or unblocked problem? I think that doesn't really exist anymore in the large majority of our cases. Multiple sinus pathologies can occur, and we heard Sarah giving a great talk about AFS with polyposis. I'm not going to go into it. I'm going to talk more about the CRS with polyposis. And you can get patients with a simple fungal ball presenting with polyp in the nose. And these patients are very easy to manage. I think there's good algorithms to treat these patients. And this is the type of patient that Stamberger and Messerklinger spoke about, this OMU construction. This is the blocked sinus, the unilateral maxillary sinus disease that we all love to have in our practice because we know how to fix it. But it's this patient here that's much more challenging. This is the patient that's much more common. This is the patient who's got mucosal disease. They've got mucosal disease in the nose. They've got mucosal disease in the sinuses. But they clearly have areas. There's completely healthy sinus. So I'm used to running this off my laptop, and I point to everything. Is there a pointer on here? Not.
There's no pointer.
There's no pointer. Okay. Well, you can all see the areas of completely healthy mucosa here. So there's areas of healthy mucosa throughout, mixed with, I don't need it, it's fine, mixed with areas of disease mucosa. And this clearly is not a blocked or unblocked problem. If you think that, then you really, really are confused. This is an inflammatory condition. Oh, thanks. This is I used to have a car that had an area like this. There is a, sorry, terrible sense of humor.
That's just hit Greg with later.
I think it came from Greg's car. But this is an inflammatory condition, and you really need to think of sinusitis as an inflammatory condition. It needs to have a focus beyond just ventilation. So if you're looking at the sinus patient and you take the pathway where you really fail to acknowledge that our understanding of CRS, our philosophy of CRS, has changed significantly over the last 30 years, and you continue to practice true ventilation surgery, in the large majority of cases, you're bound to fail. And if you acknowledge that inflammation and mucostasis is really, really playing a major role, and surgery is really a tool to break down this process and to allow us to treat these cases overall in a more medical fashion, then you're going to probably end up with a greater degree of success. And I think that the most important thing in the last 20 years is that research has shown us that this is an inflammatory condition to a large extent. And if research and clinical practice diverge, you're doomed to failure. Whereas if they work in harmony, you're probably going to have a more successful outcome. So I love this slide. This was a slide showing our understanding of CRS in the 80s, where everything was all about infection and obstruction, and it was really, really quite a simplistic way of looking at it. And if you believe that, you probably think that Madonna still looks like this. But as we got into the 90s, we suddenly discovered that polyps was a unique, different inflammatory condition, different from all the other aspects of CRS. And CRS was mainly infection and obstruction, but polyps were inflammation. And if you believe that, you probably think that Donna looks more like this. But the truth of the matter is that if you've looked at research over the last 20 years and you understand that there's actually only a very small group that's purely infection and obstruction, and everything else has started to blur over, then you'll realize that Madonna actually probably looks more like this. So, managing inflammatory sinus disease. My goals are to create a single neosinus cavity. And the reason I do this is because, number one, it allows for very, very easy removal of inflammatory hypersecretory mucus. My physician says I do an IL-5ectomy. I effectively remove the mucus and all the inflammatory mediators at the time of surgery. You also allow for effective topical access, and I'm going to talk about that in a little while. And you reduce the mucosal surface area, and in doing so, you actually reduce the inflammatory load. And finally, there's some evidence that you improve this mass mucociliary function. You don't get the little trapping of mucus behind those little cells which you leave behind if you do a less complete. I don't talk about aggressive sinus surgery, I talk about complete sinus surgery. So when I manage inflammatory sinus disease, my goals are to try and treat this area here. That's where we want. It's sinus disease. It's got nothing to do with what's going on inside the nose. It's a sinus problem. Now, is delivery to all FES cases the same? Well, here we've got a balloon case, we've got a mini FES. Here's my aerial. Balloon, mini FES, and a complete FES. Now, I don't think it takes a lot to work out which cavity is going to get better topicalization. And Sarah and Richard did the study a number of years ago where they looked at different delivery techniques. And all I really want you to concentrate on is this over here, where it shows that no surgery and nasal sprays have really no effect on the sinus mucosa whatsoever. The more surgery you do and the bigger volume nasal irrigation you use, the better the application. And this is not rocket science. There's no spray available in your pharmacist shelf that says mometasone sinus spray. It's a nasal spray, and don't confuse the two. So how do we predict which of our patients are inflammatory? Well, let's look at the asthma literature, because the asthma literature, there's huge funding. There's so much research has gone into asthma over years, and they've got a really, really good understanding of what's going on in inflammatory airways disease. And we can actually take what we've learned from the asthma literature and apply it to the sinus inflammation. So the respiratory physicians are well aware that there are different kinds of asthma, and they manage them differently. In childhood, you get this very typical allergic asthma with a Th2-driven pathway, and then as they get older, you start getting more of the aspirin-exacerbated asthma, worse asthma, the late onset eosinophilic asthma, the aspirin-associated asthma. As you get older, you get a mature onset on asthma, which is typically seen in overweight patients, typically in the female age group. And then finally, you get a delayed group, which is smoking associated and pollution associated. So how does this equate to sinus disease? Well, there are endotypic differences and similarities between the two. And what we really want to try and do is look at what group we have. And I'm going to try and oversimplify the whole concept of sinus disease in terms of how we can manage it. So our first group is this allergic group. This allergic group, typically in the younger patient, in childhood and young adulthood, they typically have rhinitis and sinus symptoms. They get congestion, they get nasal obstruction, they get facial pain. They all have the symptoms that we've always typically associated with sinus disease. And that's why I said on the panel earlier, you've got to think of rhinitis as a cause as well. And these are more related to common allergen exposure, and our management is going to be very, very different. So if we look at this patient here, hands up those of you who think this patient has nasal polyps. Good. Okay, this is not nasal polyps. This is middle turbinate edema. This is rhinitis. This is not nasal polyposis. And so we've actually just published looking at middle turbinate edema as a diagnostic marker of allergy. And we looked at a whole lot of different middle turbinates. We looked at 180 patients, and we defined 4 different, obviously normal, but we defined focal edema, multifocal edema, diffuse edema, and then polypoidal edema. And if you look at those different kinds of middle turbinate edema, what does it prognosticate for us? Well, the diagnostic accuracy and the prognostication is that if you've got a diffuse edema or polypoidal edema of your middle turbinate, the likelihood of this being allergy is exceptionally high. It's got a positive predictive value of 90%. It doesn't mean that if you don't have middle turbinate edema, there's not allergy. But if you do, it's got a very, very significant positive predictive value of allergy. And so this is a great case. This is an example here of a patient who looks like they got extensive polyposis. This is pure, gross, middle turbinate edema. And the sinuses are absolutely clean and healthy. So let's look at this patient over here. Looking at the nose, polyps, no. Extensive polyps. There's polyps filling that middle meatus there. There's polyps there. But when you look at the CT scan, all the polyps are localized within the nose. There's severe rhinitis there. And the sinuses are really quite spared and quite normal. And this is a very, very simple kind of a presentation of that type 1, we'd call it sinus disease. This is what we see more commonly, where you've got polyp in the nose and you've got secondary polyp changes within the sinuses. And this is a secondary phenomenon, and these patients have got a very, very high incidence of allergy, and these patients need to be managed in combination with your friendly allergist and looking at all sorts of different treatment options, which we'll discuss in a short while. And we label the central compartment atopic disease, where it's all based centrally. They got polypoidal changes over the septum and the middle turbinates, and then they got the secondary sinus disease. And we looked at allergy in all our patients. We looked at 106 patients with CRS, and in fact, we scored the sinus mucosa into 4 different stages, into normal, roof-sparing, mucosal thickening, and complete opacification. And we try and categorize which of these central compartment patients have got significant allergy. In terms of demographics, our group with non-atopic and atopic were very similar. In fact, the only difference was the age, which one would expect in a slightly younger age group, a higher incidence of allergy. But when we actually looked at the sinus symptom scores, when we looked at OMC, the radiologic scores, there was really no difference between the two groups. So it's very difficult to categorize which of these patients are going to be allergic and non-allergic. So then we decided to do a subgroup. We did what we call phenotype B1. We just looked at those patients who had polypoidal disease in their nose, but they had some sinus sparing. They had some normal mucosa, completely normal mucosa within the sinuses. And what we found here was really quite interesting, because those patients had an allergy level which was significantly higher than all the others. They also had patients with this type of thing had less in the way of true nasal polyposis. So we've now got a prognostic factor that we can look at that group 1 in the same line that the asthmatics are looked at as group 1. They're a younger patient. They have a higher incidence of middle turbinate edema. They have some endotypic differences that will differentiate that group from our other CRS patients. What about this group over here? The eosinophilic. These are a totally different group of patients. These are the patients, they've often had severe asthma. They often have had hospital admissions for their asthma. They're steroid dependent sometimes. They're commonly eosinophilic. They often have no history of allergy whatsoever. I won't go through the pathophysiology behind it. It's been well described. But this actually, certainly in Australia, this is our commonest group of CRS patients, these eosinophilic-driven patients. And when I was a resident in the 80s, we were taught these patients, surgeries aimed at creating an airway. What a lot of BS. That's just rubbish. That's old thought, and Madonna was 12 years old at that stage. So our single thing that's changed the way that we look at these patients is tissue biopsy. And I think that tissue biopsy is something that everybody should look at, because it really is a major, major advancement in how we manage these patients. We look at a whole lot of things on our tissue biopsy, and we get a report now that's looked like this. That last slide, I can send you all a copy of. That's easy. That we did it with our pathologists. It's very easy. It's all on H&E stain. There's no special stains. They just give us much more detail than saying this patient has no sign of malignancy and chronic sinusitis. You knew that long before you did the biopsy. So what we actually get from the biopsy are things like eosinophilic infiltrates or neutrophilic infiltrates, the status of the mucin, whether there's eosinophilic mucin or not, whether there's squamous metaplasia, whether there's Charcot-Leyden crystals, whether there's fibrosis. These are all really, really important factors in how we ultimately manage the patient. So some might say, well, why do you bother with a tissue biopsy? Serum eosinophilia is a simple blood test. Well, the truth of the matter is that that's true. It is a simple blood test. And if you've got a positive serum eosinophilia, you're going to have a high tissue eosinophilia. But there are a lot of cases where you get a very, very high tissue eosinophilia with a completely normal serum eosinophilia. So it's got to, again, if it's positive, very valuable. If it's negative, your tissue is still going to change the way you manage your patient. What about serum IgE as a surrogate? In truth, it's really a waste of time. Serum IgE is not a predictor of high eosinophilia at all, and in fact, it's not even actually a very good indicator of allergy either. So serum eosinophilia is not a good case. This is the typical case that is referred to us in our practices. Extensive disease, no mucosal sparing. You look in the nose and you can typically see this extensive polyp. That's different from that inflammatory edema of the turbinate in group 1. These here have got extensive polyps filling the area, multiple polyposis. You see this very thick eosinophilic. I think it was Don Lanza talks about the beaded mucin, where you can see actual little aggregates in the mucin. It's a very, very different scenario to that first group. And these patients here, they need to get steroid. They need to get spray into their airway. The respiratory physicians have got a fantastic way of getting it there by inhalation. But you can use a nose spray, and the nose spray has got absolutely no chance of getting up there. It's got no chance of getting into the posterior ethmoid or into the frontal or into the sphenoid sinus unless we allow it with a common neosinus cavity. So these are the patients who I think you need to be really, really aggressive. We know, I'm not going to go through this, I don't expect any of you to read all of this at all, but we know that the surgical state and the device have got a significant role to play in getting treatment in there. So where does our anti-inflammatory therapy need to go? Well, if you put your anti-inflammatory with the nasal spray into that area there, you're really, really not addressing the problem which is out there in the lateral recesses and in the mucosa of the ethmoid cavity. So what do we do with these patients? Well, steroids. Steroid, and steroid. Steroids are the single best way of getting it. And then how do we get steroids in there? Well, we can give it to them in a tablet. It goes via the bloodstream into the sinus cavities with great results. The problem is it also goes to your hips and to your liver and to your bones and to your GIT and to your big toe, for God's sake. It goes everywhere. So is it justifiable in putting these patients on oral steroids? Well, the truth of the matter is not. So we really want to get steroids into the ethmoid cavity via a combination of a wide open cavity and using a wash bottle. And it needs to be a high volume wash bottle in order to get there. Using a 50, 60 ml wash bottle is a waste of time. It's not even the dead space. So you really need to use a 240 ml wash bottle in order to get it there. So we asked ourselves, does the method of topical corticosteroid delivery impact significantly after a complete FES has been done? And so we did an RCT. We basically had patients all defined by EPOS, as CRS. They all had diffuse disease. They'd all failed sinus medical therapy. They'd all had surgery. They were all adult patients, and we excluded those with systemic diseases. We recruited them all, and they came into our study after they'd had a complete FES. All of them had a complete full house endoscopic clearance of all the ethmoid air cells, wide open sphenoid, wide open frontal sinus, and middle meatal enterostomy. They all had a 21-day oral course of steroids, and they all were given 10 days of culture-directed antibiotics. And then what was our intervention? Well, essentially, all of them had once daily nasal spray and once daily nasal irrigation. The active agent we used was mometazone, 2 milligrams. It's a very colorless, odorless base, so it was easy to use. And we used it in a nasal irrigation bottle, 240 ml squeeze bottle in a metered, we used a little pump action to give them 2 milligrams of either mometazone or placebo, and similarly with the nasal spray, it was 1 milligram per 1 ml of metered dose spray, with using 2 sprays, again 2 milligrams. So our first group had the mometazone in the irrigation, in the spray, and placebo irrigation mometazone spray, and the other group the opposite. They were completely blinded, as we were, as to what they had. So they had no idea. Both The bottle was labeled saying placebo or mometasone, and they had no idea what they were using in their pump bottle. So it was a completely randomized, double-blinded study. And what did we look at? Well, our outcomes, we looked at a whole lot of different parameters. We did all the patient questionnaires. We did endoscopy. We did radiology. Our primary outcome was visual analog scales. We looked at 10 different items. We did SNOT-20s, global function scores, and we looked at a couple of secondary outcomes as well. We looked at the Lund-Mackay score. We looked at endoscopic scores, and we looked at the amount of systemic steroid and antibiotic use that they did over the 12 months. So what were our results? I'm not going to take you through this whole algorithm, how we did it, but just to say that it took us a long time, nearly 3 years, to recruit 44 patients. And the reason for that was that patients often would say to us, well, what do you think is better? And I would have to say, I think that steroid irrigation is better. And a lot of patients would say, well, then I want steroid irrigation. And so it took us 3 years to recruit 44 patients. And in fact, we only closed this at the end of 2014. So because of our 12-month follow-up, the study only finished at the end of 2015. Whenever you do a randomized controlled trial, after you've released what they had, you want to make sure that your randomization was actually reasonably accurate. So we looked at demographics, and in fact, they all were both groups pretty much the same. And in terms of disease burden, both groups, again, pretty much the same. No significant difference at all in the two groups, which was really nice to see. What were our results? Well, what you can see is when we look at all patients, everybody actually did well, which just shows that surgery alone actually makes a difference. Surgery and a nasal spray made them better. Surgery and an irrigation made them better. But when we actually separated them out into those who'd had an active spray and those who'd had active intervention, the active irrigation actually did significantly better than those who had who just had the spray, particularly in 3 parameters: their change in their blockage scores, their change in their endoscopy scores, and their change in their radiology. And if you look at this diagram here, this is an overall score. The blue is the mometasone spray. The orange is the mometasone irrigation. You can see that's a total 100 scores, 10 symptoms, 10 Likert scale. You can see that the irrigation tended to all get better, some coming right down, whereas we had some in the mometasone spray who actually did worse after their surgery and who did deteriorate. But overall, as I said, all patients actually did better. Just breaking down our results by symptom, one can clearly see the blockage, drainage, and fever, significant difference in all 3, and overall, they all did better. Endoscopy scores was probably the most prominent. We had a significant drop in the endoscopy scores in those using the irrigation. Remember, we were blinded as well. Lund-Mackay scores, which again, an objective radiological score, significant improvement in those on irrigation. So now when I get a patient in my rooms that comes in looking like this, I no longer say to them, I'm going to operate on you to create a nasal airway. My aim of surgery, my goal of surgery, my philosophy of surgery is to remove all this disease and to create the environment whereby they can topicalize and keep control of that inflammatory mucosa, and I can offer them a significantly better long-term prognosis than I could 5 years ago. So just going back to our asthmatic patients, we got the 3 groups here. What about this late onset here? Well, this is our non-eosinophilic group. These are the groups who previously had neutrophilic or another kind of sinusitis, and these are the ones that really had confounded us, because they would present this type of patient here, 30-year-old lady who comes in with polyposis, and one can see that there's purulence as well associated here, and that's a really important feature, that purulence. And I would say to them, I'm going to operate on you, I'm going to do a full house fest, and I'm going to put you on a topical steroid, and I'm going to cure your problem. And then they come back to see you 3 months later, and you look at them and you go, my God, Sax, you are bloody hopeless. Because they come back and they actually look worse. They've got significant sinus disease, they've got extensive symptoms, their SNOT-22 scores are absolutely terrible. These are the patients that really gave us the most problem. And always we had this clinical mojo of these neutrophilic type of patients. We used to say that they're typically female patients, they're typically overweight, middle-aged patients, often with less polyposis, with a low IgE level. And this was what was published in the literature for a long time. And we thought we need to be more scientific about this. So we took our tissue profiling and we looked at our tissue profiling, and you can see that the key thing here, eosinophil count, less than 10 per high power field. This is actually that lady that I just showed you the video. This is her histology report. So less than 10 eosinophils per high power field, severe subepithelial edema, absent squamous metaplasia, and a neutrophilic response. Significant neutrophilic response. This is her histology. And so those patients we put onto macrolides. Those patients we put onto macrolides, and this is her 3 months after macrolide therapy. It's not an improvement, it's a dramatic improvement. And these patients really, really do well with macrolide therapy, and we are not using it for its antimicrobial effect. We're using it for its immunomodulatory effect. And in certain Asian countries like Japan, they have the majority of their CRS is neutrophilic CRS. That's what they see. And that's why most of the studies on macrolide therapy came out of Japan, because they do really, really well, these patients with macrolide therapy. Sorry, I'm going to just... So we wanted to define in that last group, what is a macrolide responder and who isn't a macrolide responder? Because we want to differentiate. We're not going to just put them onto something that's potentially toxic if we're not going to get a good response. And so we looked at all our patients. We looked at a whole group of patients who we'd given macrolides to. So they were all in that last group of patients. We'd given them macrolides, and then we looked at those that responded and those that didn't respond. And what we basically found was a significant 3 different factors: serum eosinophilia, tissue eosinophilia, and squamous metaplasia were statistically different in the macrolide responders to the non-macrolide responders. And so we actually concluded that you can define your macrolide responder. The patient who's got a low serum eosinophil, the patient who's got a low tissue eosinophil, and the patient who has absence of squamous metaplasia. Those are the ones that you should put onto macrolides, and you're going to get a really, really good result. And this has been borne out now since our study in clinical practice. We get very, very good results with macrolide therapy in those patients. So if we go back to our final asthma slide again here, we've really looked at the way that the respiratory physicians have categorized asthma and how they treat it. So we've kind of tried to categorize them as that first group being the younger allergic group, where we're going to treat them with surgery, open it up, and involve our immunological colleagues with allergen identification, with desensitization, with a whole host of new generation treatments that were spoken about earlier today. That group does really, really well. The second group is a severe asthmatic, steroid-dependent eosinophilic CRS patient. They need aggressive, complete surgery and long-term topical steroid therapy. Telling them not to use it long-term is the same as, an asthmatic patient who's doing well on long-term steroid inhalers and then goes on to a mouth gargle. You've got to get it into the sinus. You can't convert them from being dependent on irrigations to being dependent on nasal sprays. Doesn't work. They do really, really well with long-term irrigations. And our later onset are the patients, the neutrophilic patients, that we tend to now advocate macrolide therapy in. So Pulmicort is what we use traditionally, and I think that's pretty much the same in the US, if I'm not mistaken. We use a 200 milligram in a 2 ml solution, and we put it into a 240 ml wash bottle, and we irrigate on a daily basis with that. And I tell the patients that it's like being diabetic, and because they're controlled on the insulin doesn't mean they can stop the insulin. And I think that you equate it with asthma, and it's a long-term therapy of which surgery is creating the environment for the long-term medical therapy. We use clarithromycin. There's variations on the theme. We use 500 milligrams of clarithromycin, and we use it up to 6 weeks. Some people use it up to 3 months. I tend to use 6-week dose. And I'm not going to take you, because of the interest of time, through this case. It was just how I do a polyp patient. That's the result. And in conclusion, our philosophical approach and the literature has changed significantly, and we really, really need to start looking at the way we change our practices in response to the philosophical approach changes. And I think that high-volume topical therapies, like topical steroids, in wide common cavities are really the optimum way to treat eosinophilic chronic rhinosinusitis, which used to be a major problem for us in the past. Tissue profiling really guides our post-operative treatment. It tells us whether we should be using macrolides, whether we should be using long-term steroid or not. And it's really made a difference to the long-term outcomes in our patients. And I reiterate this point that when you think long-term prevention, you've got to think asthma. You've got to consider all the factors when prognosticating. And most importantly, you've got to be realistic about what you can or cannot achieve. I thank Greg for inviting me here, and I invite you all to join us in Hawaii for our combined South Pacific ORL forum, where we're going to have fantastic rhinology. We're also going to have fantastic pediatric otolaryngology because there's a combined meeting with the Pediatric Society and, in fact, with the New Zealand ENT Society. So thank you very much, and I'll take any questions.